I am Valentin Fuster from New York, and I'm very pleased to chair this session, a very international session with 6 outstanding people. We are in Munich. This is the European Society of Cardiology. The weather has been fantastic, and the show promises to be fantastic. We are going to touch into what went on in the meeting. It was an interesting meeting. On one hand, we have a number of trials that were quite disappointing and surprisingly were negative. We'll leave this towards the end. There were studies presented about promoting health, the problem of the epidemic of cardiovascular diseases, what we should do. We will start addressing these issues. And then there were some 2 or 3 studies, technically speaking, interesting. One on antithrombotic therapy and atrial fibrillation with coumadin and platelet inhibitors, and another actually clipping of the mitral valve. Very interesting registry from 4 countries. So we are going to touch into health, into these technological advances that I just mentioned, and at the very end we'll make a summary of the negative trials, some of them actually quite surprising. I'm going to introduce my colleagues today. From my right is Dr. Adrian Brady, Associate Professor and Consultant Cardiologist at the University of Glasgow and Head of the Department of Hypertension at the Glasgow Royal Infirmary. I spent some time with the competitors. I was at the Royal Infirmary of Edinburgh for 3 years. Here we have Dr. Elaine Hylek, Professor of Medicine at Boston University and Director of the Thrombosis Clinic at the Boston University Medical Center. Further, we have Dr. Peterson, Director of the Duke Clinical Research Center. Warmest congratulations for the new job.
Thank you very much.
And we wish the best to Dr. Bob Harrington, now Chairman of Medicine at Stanford, that really was part of this panel for a number of years. We now have here on my left Dr. John Eikelboom from McMaster University, a hematologist. He's Associate Professor of the Department of Medicine. And then we have Dr. Georg Ertl. George is in an American way. George, I guess, is in a German approach. Director of the Department of Internal Medicine of Comprehensive Heart Failure Center at the University of Würzburg here in Germany. And finally, we have a surgeon. We don't forget you. Dr. Subodh Verma, Associate Professor, Division of Cardiac Surgery and Canada Research Chair in Atherosclerosis in St. Michael's Hospital, University of Toronto. As I mentioned, 6 great colleagues who are a very international group. So I hope this works well. And let's now begin to the studies that I said relate more to health. And the first one was the PURE study. This study has a background. It was actually published in The Lancet about a few months ago. And it's a study in high, middle, and low economy countries that was presented by Dr. Salim Yusuf from McMaster University. 150,000 people, which actually were surveilled for lifestyle. The study presented in The Lancet was interesting. Basically said that if these people have a cardiovascular event in a low-income country, the chances of taking the right drugs is less than 10% because of economy, in part. And in rich countries, actually less than 50% of the people who have cardiovascular events are taking all the medications that they are supposed to take. So this was is a reality and is a real problem when we talk about an epidemic. This time, the presentation is different. It's touching into what is wrong that leads to the epidemic of cardiovascular diseases. And it's interesting. In poor countries, first, people eat carbohydrates because it's cheaper. So you end up with obesity and with diabetes through that mechanism. In rich countries, saturated fats, you end up with obesity too, but through a different mechanism. And at the same time, there is less and less exercise in people who are in high-income countries, again, moving towards obesity. Then there are other problems. Hypertension. We already know very well the incidence of hypertension in high-economy countries, but it's becoming very obvious that this is the #1 cause of cardiovascular death in poor countries. Why? Because the foods are kept with salt, very salty cooking, and this is what is leading to hypertension, so it's a huge problem. And finally, cigarette smoking. Interesting. You would say, well, we smoke more in high-economy countries than in low-economy countries. Actually, it's the opposite. Smoking is decreasing in high-economy countries, 25% of males in general, where in poor countries it's close to 50%. It's going up. So we have a problem with obesity, we have a problem with lack of exercise, we have a problem with hypertension, and we have a problem with tobacco smoking. Eric, tell us, what do you think about this data?
No, I think these data are great. It highlights sort of two factors for me that I think are very important. The first of which is to think about cardiovascular disease as a global epidemic. And I think you very well point out that it's not only in the larger developed countries, but now as much in the developing world, or perhaps even more. The second is that we need to emphasize primary prevention. This study was a great one to emphasize the risk factors we've known for years, but have not done well as a society or as a global world treating.
Adrian, we have two approaches here, to be simple. One approach is government, society, to really have an impact on the environment. And I think a clear example is smoking, in which the laws have gone from country to country and is decreasing. The other is what can we do at a more local level, we have a project in Grenada, in the island, in the Caribbean, and another in Europe, in a little town, which adults help each other, like Alcohol Anonymous, in helping controlling blood pressure, obesity, and so forth, in groups of 10. I'm just presenting two different approaches. You have a tremendous experience with hypertension. Tell us what you think about this data that is coming out from PURE.
Well, I think the messages are clear that despite the modern developments of statins and drugs and so on, the fundamentals of diet and of exercise and of hypertension, which evolves, as I say, probably through salt in the diet. We know the WHO has come out 2 years ago and said that hypertension is the most important risk factor of all. But I think what Salam showed in this group was really diet and exercise underpin everything. And the sort of changing global dynamic of less exercise, more obesity, more saturated fat in the more affluent populations, that drives atheroma. But really, it's the loss of exercise that, to me, was the big finding from that study. And you suggested the projects you've been addressing in some countries. In Scotland, we've been using the local football teams. So all the national teams are the cities teams. Each has a health program taking football fans, overweight middle-aged men, through diet and exercise programs. And that is very exciting. And so this is now a national scheme within our country, and we hope to export this to England, to Holland, and to Spain. This is developing shortly.
Elaine, I have a question for you. Mm-hmm. Children we should go to young kids. That's where behavior develops. This is a disease of behavior, basically. Why we don't go into the 3, 5, 7-year-olds and we really use that window of opportunity?
Well, there has been, I would say, I'm most familiar with the United States, a huge push now to look at the types of foods that are in vending machines, for example, what type of lunch is being served in grade school, so that I think we're finally owning the fact that we are contributing to this epidemic of obesity. You know, in addition to that, I'd like to just briefly revisit this cigarette smoking, because I feel when you're a physician and you see the ravages of cigarette smoking and amputation and strokes and heart attacks, it's unconscionable to think about the export policies that we have around cigarettes and tobacco, that they're not exported as toxic substances. And I think that there's a lot that could be done on a public policy platform to try to decrease the exposure worldwide.
But Elaine, don't you think that one of the real losses from modern technology, it's a condition called FOMO, fear of missing out, And so if you've missed social network conversations with your friends, then you've lost something and you're slightly behind your social group if you're age 9 or 11. And I see this, in my own children, it's time on their computers rather than
exercise.
So you're losing exercise. You're sitting in front of a computer screen or your handheld iPhone or whatever.
You just have to buy a couple dogs and get the kids out with their dogs.
Maybe, but I'm not sure that's the whole answer.
Right.
George, from your point of view, what do you think? We are really facing a reality here. Cardiovascular disease is increasing. The thing is, don't allow people to die, but it's increasing. People live longer because they go into hospital in and out. And it seems to me, I don't know, the example of Bloomberg in New York is quite remarkable. This is the only mayor who has the power over health, and he has been able to really, he's changing New York in terms of the issues, salt and reduction, and getting into the restaurants and really penalizing if the oil being used in cooking is not the appropriate one. You don't see anybody smoking there, even in Central Park. It's quite remarkable. What do you think, I mean, in general, what we should do? It seems to me we have to really go into the higher level and then change the environment. This is what Yusuf is saying. He says this is a drop in an ocean, and we have to change the ocean.
So first of all, I think we face a global problem with cardiovascular disease. We always thought that in the poorer countries, infectious diseases are the problem, but now obviously cardiovascular disease is catching up. I was the discussant on the hypertension part of the QS study, and for me it was very interesting, first of all, that control awareness of hypertension were very low globally, but then in the poor countries, in urban areas, the control and awareness was quite similar to the rich countries. But in the rural countries, it was virtually zero. So I think that's one problem we have to face. In the rich countries, of course, I think to our youth, and I have 5 children and 7 grandchildren, so I think prevention has to make pleasure. They have to enjoy. Mm-hmm. So that's probably what we have to try to bring at our young people. We notice obesity goes up in Germany. There has been a study here at the ESC. But we also see that stopping smoking in official areas and in restaurants has decreased myocardial infarctions by 25%.
Well, actually, John and Subodh, we are going to discuss another aspect which has to do with the FAST MI registry in France, which really goes in the same lines as what we are discussing here. And basically, in France, they have a good registry of coronary artery disease, and between 1995 and the year 2000, on 4 occasions, they surveilled during a period of a month the myocardial infarction outcomes and so forth. And the total number of myocardial infarctions that were included were close to 7,000. And in this registry, there are good news and bad news. I mean, the good news is the mortality from myocardial infarction in France has dropped from 13% in 1995 to 4% in the year 2010. On the other hand, the use of medications has improved reperfusion from 49% to 79%. This all looks very good. However, there are some news that are not so good, and that is the mortality decrease in men has been significant, 9.8 to 2.6, but in women is still 10% with myocardial infarction. And now we are going to focus on women. In fact, 25% of myocardial infarctions now in France in women are below age 60. And actually, women under age of 50, the incidence of infarction has increased from 3% in 1995 to 11% in 2010. So we have a problem with young women and myocardial infarction. And actually, these women do not have a significant number of risk factors except one that is predominant, is cigarette smoking. And then is followed by obesity. So I'd like just to focus the discussion on cigarette smoking and perhaps of obesity and in young women, because this is a real problem on this registry. And this also fits to some of the issues that we just discussed on the pure presentation. What do you think, John, of all of this?
Well, a very concerning trend, the increase in smoking in women. I think this comes back to your earlier comment. We have an ocean of risk. We've got to change the ocean, and it's going to be done drop by drop. And on the one hand, we're lulled into a sense of security that in places like France and elsewhere, we see reducing mortality from myocardial infarction. And yet here, a sobering reminder that we haven't won the battle, and we need to tackle these issues in a systematic way. Women and smoking is a crisis emerging, and we need to renew our efforts here.
So though you're following his comments, you are now in the executive cabinet of the government of France, and I give you a figure. The figure is in 2010, the number of women that were smokers was 37%. At this time is 73%. What would you do?
So, before I answer that question, I just want to make one comment that just sort of follows the preceding discussion from Pure, and that is, rich and sort of poor countries and looking at cardiovascular outcomes. I think it's important for us to remind ourselves that rich does not always equal less disease, and poor does not always equal more disease. And we sort of always look at sort of these two populations and make judgments about their cardiovascular risk when we know that a large proportion of cardiovascular disease is actually evolving in countries like India and other places where there's a rapid growth of middle class.
Almost number one killer.
Absolutely.
Yeah.
So, if you look at rich countries like Canada, United States, and France, it's hard to reconcile the increasing rates of risk factors, despite the fact that they're sort of, an urban, rich environment. So I think we have to understand the fact that, risk or societal risk is really contextual, and sort of appreciate that there's much more to this than just sort of the dichotomy of rich and poor by GDP, for example.
Well, the incidence actually is becoming very similar in rich countries and in poor countries, or high economy and lower economy. But the mechanisms are somewhat different.
Absolutely.
But you reach the same type of a situation.
Absolutely. I think of some rich Torontonians who have personal trainers who run on the waterfront every single day, who've got dietitians who watch what they eat. And then I look at the same rich people who live in India who have a very different way of lifestyle. So I think the sort of contextual basis of diet and exercise is an important consideration as we move forward, and also the fact that the use of risk reduction therapies that is so low in Pure. I think that was the overarching message from the first publication, that we have cheap, inexpensive therapies, yet maybe we don't appreciate what patients weigh and rate as being the most important determinants of them using these therapies. I'm sure if we exchange these 4 sort of pills with 4, vitamins or minerals or other types of products, the compliance rates may go up. So, I think we need to appreciate what is important to patients and what they rank as being the most important determinant of them taking their therapy and moving forward.
At least what is important on these presentations that we are discussing now is to make all of us, all of us who are in the medical field or in health, to appreciate that we have in front of us an elephant that we have to take care of. And unless we have these discussions, things will continue to go into the wrong direction. So I think it was very appropriate, at least these presentations, and that we had this discussion. I don't know if there is any further final comment. Eric, you are very much in this field. You have any final comment to make?
Now, I would just say that I think it's wonderful if you think about this array of physicians thinking about issues that are important in terms of policy and then personal decision making that are really going to be the strong determinants of the future of cardiovascular disease. That we're now investigating these, that we're exploring how to do better in this field, moving beyond just the delivery of health care to looking at health more broadly, I think is a great step.
Elaine?
Valentin, I would very much like to add regarding this staggering statistic with young women smoking, is you have to ask yourself, who are those role models? You know, what are these women reading? And if you open up some of the most popular magazines for those age groups, the amount of advertising that comes from cigarette and tobacco, I think, is very concerning. In addition to that, I think we have to tease out the stopping smoking, but I might gain weight phenomenon that may also be fueling part of that. So it's, I think it's a real call for action.
Yeah, I agree completely. It's a call for action.
Yeah, I mean,
of
Elaine,
all of us.
I would add to that. I mean, you're absolutely right. You can make national policies to ban smoking in public places and so on, but it's advocacy and leadership. And I think it worked for breast cancer. You know, make breast cancer public so that everyone knows about it. Screening is important and it works. And that's worked very well among women. And so we need advocacy in these countries to say stopping smoking is good. And then that might be a powerful public health message.
Credible role models.
Credible role models.
Anyway, I think I would say that all of us have a huge responsibility in the field of advocacy because we are in the field. And I think we should be able to convey in all of our people that we are in touch with, not only patients, but part of society. We should be, in a way, try to be an example of what should be done. I hope advocacy can have a tremendous impact. Anyway, let's move now into an area which is closer to the daily practice, and this is just patients with atrial fibrillation who are on Coumadin, and 30% need a stent sometime. So what do? The stent, it seems, requires aspirin and clopidogrel. Atrial fibrillation requires anticoagulation. Are you going to give the 3 drugs? Well, this is the issue that has been addressed actually in the last hour in this meeting is the WOEST study, which was presented by Dr. Willem de Wild from the Tilburg in the Netherlands. And it's an interesting study. It's 573 patients with atrial fibrillation in which they receive stents, and these patients receive either bare metal stenting or a drug-eluting stent, and they were randomized into the 3 drugs, clopidogrel 75 milligrams, aspirin 81 milligrams, and Coumadin, and the other group was Coumadin and clopidogrel. So aspirin was dropped. And these patients were followed for a period of a year, and the results are quite remarkable. Bleeding did not increase with the 3 drugs, with the 2 drugs, clopidogrel and Coumadin, compared with the significant amount of bleeding when the 3 drugs were given. Something that is in the literature but was never a randomized study, and the number of ischemic events was no difference. So actually the conclusion of the study is that patients who require Coumadin and they undergo stenting, the use of Coumadin and clopidogrel is sufficient to certainly prevent bleeding and ischemic events, certainly for a period of a year. So I would like to ask you, maybe John and Elaine, who you are very much in the hematology field, are you surprised about this information?
So not surprised, but excited by the data. Finally, some high-quality data from a randomized trial, a small trial and not powered, say, for stent thrombosis, but incredibly important for patient practice. We see this every week. What do? Triple or dual therapy? This is going to increase my confidence in using dual therapy, but we still need more studies.
Elaine?
I think I would echo what John said. I think this is an area of atrial fibrillation that remains a real conundrum. What we do in individuals at high bleeding risk is favor a bare metal stent to get away from the hazards of triple therapy. The first question from a methodological standpoint what is the mean age of this particular trial, because I think we see most of the bleeding among individuals that are over 75. But this clearly will finally give us some evidence that what I think several of us have thought about might be the best option. But finally we have some real data to support it.
Good. Eric, are you excited?
Yeah, no, I think it's phenomenal that these investigators finally went to the stage of not adding on one more drug, but the idea of can we get a better combination that would succeed in our getting the endpoints we want to see. Dropping aspirin has been sort of sacrilegious in our practice. We see it now in this study. I suspect we'll see it in other studies in the future, trying to get that right combination of avoiding bleeding but retaining the thrombosis benefits.
Good. Any other comments? George or Adrian?
Yeah.
Go. Yeah.
I think this is very exciting, and it's actually slightly contrary to the message that we've had for a couple of years from the very large Danish registry, which looked at bleeding events in people on anticoagulants with aspirin and clopidogrel, and it showed in that registry that adding aspirin to warfarin didn't convey very much risk, but clopidogrel had a much higher bleeding risk. Now that's a different population. So this study with angioplasty and stent insertion, I think, gives tremendous reassurance that warfarin plus clopidogrel seems a great combination, and there's not the excess of bleeding that was seen in the ACS registry. And so now that for the first time there's a trial which actually gives a different result to a registry, so that's very important.
Well,
and will affect our practice.
the other important piece would be what was the range, the INR range, and if that was must have been the same, I'm assuming, in each. Oftentimes it's 2 to 2.5.
I don't know exactly the data because, in my understanding, it has not been published and just presented an hour ago. So, but certainly I think is important that we discuss because I think the impact is very significant. George, any comments?
Yeah, for daily life, it's just a great study, and I was a little bit surprised about the design that they dropped the aspirin instead of, let's say, clopidogrel or going on with aspirin plus clopidogrel. But I think the major second message is, again, stay with a bare metal stent in the old people with high risk of atrial fibrillation.
Sure. So what?
I agree. I think there is one other element that should be mentioned. We don't expect warfarin to reduce stent thrombosis, and the trial was not powered for stent thrombosis. So the interventional cardiologist will say, we need a bigger study to make sure we're not paying for this with an excess of stent thrombosis. The new oral anticoagulants we've seen in 2 ACS trials can reduce stent thrombosis. So what an attractive option that would be, a new oral plus clopidogrel, because you would additionally, we would hope, reduce stent thrombosis.
So you can design the trial.
I think we urgently need a trial like that.
And you're a hematologist moving into cardiology.
He's rapidly scribbling ideas
Yeah.
right down on his pad
He's
right
moving-
now.
he's
Good
moving
luck
on.
with that one.
Well, anyway, let's now, after we discuss issues of health in general, something that we see every day, which is atrial fibrillation with the stenting, let's move on something that we don't see every day, but technically speaking is a significant advance, and this is the mitral clip. We already have data from the Everest study, which was a study that, if I recall, it randomized patients with that were sick patients with mitral valve disease, but they were eligible for surgery, and they were randomized into surgical intervention, which is percutaneous with a clip in the mitral valve, unifying or at least adhering the leaflets to decrease the incompetence in the group that was treated surgically. And the results were, well, it's feasible. This is a technology that is feasible, but the surgical results are much better. This is actually what we learned last year. This is actually a registry which has been in 4 countries, Denmark, Switzerland, Italy, and Germany. It's a registry of about close to 600 patients. And this was presented by Dr. Wolfgang Schillinger, who is at the University Medical Center in Gothenburg. The registry is quite fascinating. These were very sick patients. In fact, they were not eligible for surgical intervention. Renal disease, the liver disease, low ejection fractions, significant coronary artery disease, average age 74 years, many comorbidities. So this is the type of patient that is very sick, is very symptomatic because of significant mitral regurgitation. And the question is not just whether you can decrease mortality, which probably you don't, but can you improve the quality of life by something so simple, at least conceptually, like the clipping of the mitral valve. And the results were remarkable. Actually, the data that has evolved is, well, first in terms of mortality, 3% at 30 days and 17% at 1 year, which is what you expect in these very sick patients. But the mitral regurgitation decreased from grade 3 to 4 to grade 2 in 80% of the patients. Interesting, functional class from 3 to 4, it actually moved into a functional class of about 2 within a year. And then was a significant quality of improvement of the patient, not only in terms of functional class, but the average 6-minute walk improved by 60 meters, which is very significant. So I would just say that this is an interesting technique. I don't know what the technique does for mortality, but certainly we all see these patients with significant functional, maybe mitral regurgitation, or even structural mitral regurgitation, in which I think we may offer at least a quality of life, although maybe not for too long, but it could be quite justifiable. So Subodh, you're a surgeon who have a view of all of these. How do you react to this mitral clip situation?
Right. So I have an interest in mitral valve repair, and you come from the one of the top centers of mitral valve repair with Dave Adams and others. As you know, the results of mitral valve repair, when done open for sort of myxomatous degenerative mitral regurgitation, are absolutely fantastic. The rates of mortality are exceedingly low, and in fact, the guidelines that we currently have to openly repair mitral valves in so-called asymptomatic patients with severe MR are also becoming more sort of less stringent. So, and that's all a result of, I think, excellent surgical technique, understanding the sort of mechanism of MR, and getting consistent with good repair techniques. And I think that trend needs to continue. But on the flip side is this really exciting information where we have a significant unmet need of a large number of patients, not just with myxomatous degenerative disease, but also people who have sort of functional severe MR that clearly is causally related to their symptoms. And I think that's one thing that we need to think about, because oftentimes we're looking at these elderly, frail patients who are short of breath, and it's up to the clinician to establish that really their symptoms are largely attributable to their leaky mitral valve. And if you're convinced that that is the case, and that the surgical rates are prohibitive and the morbidity is sort of prohibitive, then I think we've been struggling after the results of Everest, because Everest was not really a trial that really evaluated this so-called no-option patient. Right. And that's really where this registry is such an advance. And I think, to me, Dr. Fuster, where the rubber hits the road is the results have to show significant symptomatic benefit to be worth the cost that it's going to be. And I think that all this is not a randomized trial, and maybe a randomized trial should be done. But I think what it does tell us is that the signals of symptomatic benefit are quite substantial. And if that is true and holds true in clinical trials, then I think the uptake of this new technology will be much faster.
Actually, two comments
much
about
promising.
what you said. First, there are two trials that are evolving. Right. One is the COAP trial, which is in the United States, and the other one is the Reshape HF trial in Europe, which actually are going to address the issue you are discussing, to be sure that there is a significant improvement. And these patients are going to be randomized into conventional medical therapy and the clipping. These patients will not be eligible for surgical intervention. So I think these trials are going to be important.
I just wanted to add that, as you know, this week the ESC has also come up with a valve guideline update. That's a joint update between the cardiology and the surgical associations in Europe. And the percutaneous mitral clip is a so-called 1B indication now. in people who are deemed by the heart team, which comprises a cardiologist and a surgeon, to be inoperable with high comorbidities and who have at least a 1-year life expectancy. So I think that we're already seeing uptake of this. It's moving in the sort of appropriate direction.
I have a little concern. Maybe Eric, see how you handle this. In Germany, and maybe George. In Germany, there are almost 5,000 patients already had mitral clips. And there are a number of articles, actually in the last 2 months, in the journals about the cost of percutaneous valve replacements. Is not some concern about it that maybe we are now moving into people who the lifespan is not going to be too long, and on the other hand, we are going to use more and more technologies that I'm not entirely sure can be justified. This one we discussed, if this improves the quality of life in these very sick patients, maybe it's justified. But I'm a little concerned about the numbers that you read.
Right. And I would say a few things. The 2 words of positive are noted, the interest of changing quality of life and the interest in actually getting more science of these brand new GWIS technologies in valvular treatment is actually great to see. If you think about how our guidelines have been guided mostly by the experience as opposed to real evidence, this is a big move forward. The 2 words of caution, though, are in part, this is still a registry, and I think that it will need to be backed up by the trials that you say to be assured that the improvements we're seeing are not just a fact that good medical therapy now just improve these patient populations. And then the other is where you're sort of hinting at, the degree to which these technologies, when diffused out into general populations, will get similar findings. In part, some of these procedures are technically quite challenging for not only the interventionalist doing the procedure, but the selection of the population we talked about, the heart team being involved, and then the imaging team that surrounds them that will actually help select that right patient for the benefit.
Okay, Elaine, any comment? First, George, you really know this country well. What do you think about the comment that I made about the numbers?
It's
very astonishing.
Well, I think it's very well taken due to the liberal law in Germany for medical technology. We can implant very quickly these devices, and we are reimbursed for that, and that's different to other European countries. So there is obviously danger that that is distributed too fast to centers which do not have long-standing experience with other types of interventions, and the indication is crucial. It needs to be done in cooperation with the surgeons, since if the surgeon tells us I can operate this patient, then he has to be operated. And the third thing, of course, and that everybody said that, is we do need the data of the randomized trials, since we have seen so many results from registries which at the end did not prove being true in a randomized trial.
Elaine, any comments?
Well, I would just comment on the difference of the endpoint of mortality and functional status and symptomatic relief. And I think it's very important that we recognize the importance of symptom relief, because it's really, if you have a family member or someone else, I mean, you can understand how that's critical. And I think now that we have standardized tools that are reproducible for symptoms, whether it's atrial fibrillation or extreme MR, I think that has at least elevated the science of this as an endpoint. But it really, with the U.S. right now, with the GDP of, I think, 18%, and we're trying to pull back on procedures, I mean, this will be closely scrutinized.
I think it's an important comment. In the ambulatory patient cardiology and cardiovascular therapy, the greatest impact is in quality of life. So I think this is a good point, the one you are making. We should pay attention to, but obviously to the cost also.
Right.
Adrian?
I mean, we've seen this before. Remember when angioplasty was introduced? It was global overnight, and there was no trial, no guidance ever. It had to be much better than medical therapy. Then after a few years, we had the COURAGE trial showing, in fact, they were more or less equivalent. But having said that, although this is perhaps racing ahead in Germany more than other countries, the results are fabulous in this incredibly difficult population that we all see in our daily practice of the elderly, often female with comorbidities, very hard to treat. I would be encouraged, but yeah, we absolutely need a trial.
Yeah, but I think we need to be more cautious about the uptake of these technologies. And to hear there's a level 1 recommendation based on technology that hasn't been that well evaluated. We've seen precedents with closure of PFOs and sucking clots out of brains, and before we know it, many physicians won't participate in trials because it's entrenched in practice. And I'm very concerned about premature adoption.
Subodh, can I ask you a question? These new guidelines, it was easy to go into 1B? I'm just curious.
Was it easy to
move?
Oh, I think it's the first time there's.
It's quite surprising.
Right. I hope I haven't misspoken, but I did see a 1B. But again, it was with certain caveats. And having said that, those caveats include the heart team and inoperability and 1-year survival and things like that. But in reality, what happens, and I do appreciate what John is saying, is that, there's the creep phenomena, right? You have a guideline and then suddenly, we've seen this again with asymptomatic severe MR. People are operating on asymptomatic moderate MR. And, so that starts shifting a bit. And I think the 1B indication is certainly quite strong in the absence of a randomized controlled trial.
Well, I think we have to pause for a moment and go into other aspects. So we discuss health, we discuss very common patients that we have in our practice with atrial fibrillation and stenting. We discuss something that technologically is like something that we never thought years ago it could happen, that percutaneously you could repair a mitral valve. It seems it's moving in that direction. But let's now discuss other aspects in these meetings that were quite surprising, I would say, negative studies of something that we thought should never be negative. And there are 4 studies of 5 that I like to comment very briefly and discuss. The first is the intra-aortic balloon support for myocardial infarction with cardiogenic shock. I mean, I evolved even as a student that was the only way to move forward and to change mortality. And over the years, nobody convinced me otherwise. Well, the trial presented here, just published in the New England Journal of Medicine, may convince us in another way. This was a study that was based in Germany, presented by Dr. Thiel and from the University of Leipzig. And the study actually involved 300 patients on intra-aortic balloon pumping and 298 that were a control group. All patients came with myocardial infarction and cardiogenic shock. And to just present the data succinctly, the mortality in the control group was 39.7%, in the other group was 41%. In the intra-aortic balloon pumping was 39%, in the other was 41% in the control group. The results obviously were not significant, but what is interesting, there was no significant difference in respect to major bleeding, peripheral ischemic complications, sepsis, and stroke. So, very surprising to me. Eric, why you don't take this one, and then maybe we will ask a surgeon what the views are.
Yeah, so in part, I think why is this so surprising to us? Because our own anecdotal experience would say both findings should be different, right? That we see benefits in individual patients when we put in balloon pumps who are crashing. And we also see patients who have balloon pumps put in who have complications, neither of which showed in this study. I think in part it in part says that we have to do trials in part to find messages, but it also takes sort of dissecting this trial a little bit more closely. I'm a little concerned that the overall mortality in this trial was somewhat lower than we'd seen in other shock populations, so that perhaps it might have been put into a population a little bit too broad base for which to see the benefit. So again, I want to look more closely at whether or not we could find subgroups for which there were benefits.
This is a 30-day mortality, by the way.
Yep.
I don't know, looking longer
Longer
it
term,
would
you
be
might see
somewhat
more,
different.
So, first of all, surprised. unexpected finding. And I think I need to read the paper to again, look at some of the subgroups, because, the top line results, I don't know if they're necessarily going to change my practice yet, because, I am colored by several anecdotes over the years where there has been clear, demonstration of hemodynamic stability, at least at the bedside, that, and I will probably still continue doing that in some patients. Now, having said that, we don't get involved as surgeons at this point in the algorithm. We're usually called when the balloon pump is in and when the thought is about sort of urgently intervening in a patient cardiogenic shock, which, is still highly debated. And despite the results of the sort of shock trial, the initial shock trial, I think our group is split as to whether we want to embark on that high-risk intervention or not in the absence of appropriate, support. So I think we'll first have to see whether this distills into any change in practice and whether there are subgroups that will benefit or not. But I think it will also bring into question whether other alternative support devices, that such as, LVADs, ventricular assist devices, etc., are also put under the same sort of umbrella, because that sort of crosses into our area.
What is interesting, though, going into what Eric said, this has to be looked very carefully. A large number of patients, I think 86%, this was done post-PCI, post-procedure. Maybe it's done too late. And maybe what we should do is to move much earlier. I don't know. This is a possibility.
Or the people who were about to die were excluded, so the very sickest patient whose life could be saved were not included in this trial. And I think that's one of the problems when doing trials in very sick populations. Do you randomize the patient who is the sickest? And so I think it's going to be very difficult to interpret this at the bedside, and I think we're going to continue to see pumps used, maybe with a little more caution in the less sick patients.
This is interesting. If I had a patient, if I had a patient with cardiogenic shock, and I had to randomize the patient into intra-aortic valvular or not, I don't think my patient would have entered that trial.
We contributed to that trial, and it was very difficult to randomize.
So maybe some selection here, which is makes the trial not so clear.
Yeah.
You had a comment, Subodh?
We don't know. These are all people who had PCI, right? They're not reporting on those who actually, maybe a minority, who ended up in the operating room for revasc. And I think that there are other reasons to put in a balloon pump when people end up in the operating room. So,
Elaine?
Is this truly the first randomized trial?
It is.
Speaking to the earlier discussion, it's just interesting. And has the epidemiology somehow changed compared to the anecdotes that we had in training compared to now?
Well, the technology has changed tremendously. The catheters are much smaller, very simple to use, so the machine is working very well, and so...
I want to comment on... There was another trial actually called BCIS-1. The patients actually were not so sick, were patients with low ejection fraction. So this is the first trial, I believe, with the so sick patients in which with an acute myocardial infarction. Any further comments, Adrian?
You could say, as Eric said, the mortality was not that high, and these were going in post-angioplasty. And maybe it shows that if you put balloon pumps into people that don't really need them, it's not going to make much difference. And the anecdotes, which we've all have our own clinical practice, where clearly the balloon pump has bridged the individual to theatre or angioplasty or surgery, I'll still continue to use them for those occasions where it's definitely going to work. And they're never in trials.
Except when you say the mortality was not too high. This was actually the mortality I thought was for about 40% to 50% in patients with cardiogenic shock. So
it was 30% in the trial?
No, 39 to 40%.
Yeah, I still think that those that benefited were lost among those in which the pump made no difference.
Okay. Any further comments?
Just one quick caveat that we criticized the trial, but fantastic achievement to do the trial.
And how difficult recruitment must have been.
I can imagine.
Yeah.
Had to be very difficult. But anyway, it's interesting. Give us at least the sense that we have to think more and more about what we thought is dogma. Actually, the guidelines change already the European guidelines downgraded the intra-aortic balloon pumping from 1C to 2B.
1C.
Those guideline writers.
Yeah, they
Anyway.
I represent the ESC guideline committee, and I'll hear nothing against
Well,
We're very fast, so we react to changes in
just
data.
get into strike. Anyway, it was a negative trial. We have few others which are interesting too. One of them is actually the prasugrel in the TRILOGY ACS study presented by Dr. Magnus Oman from Duke. There is a study, the Triton TIMI 38, which were patients with acute coronary syndromes that they underwent intervention, PCI, and at that time prasugrel was compared with clopidogrel. And the results were quite significantly in favor, except in a group of patients who were elderly patients over age of 75 and people who were rather thin. And if I recall, also patients who had previous stroke. I'm not entirely sure, but
right.
there were some. So prasugrel was a winner. Well, in this study, it's not. And basically, of these patients who present with an acute coronary syndrome, about 40% because of comorbidities or otherwise are treated medically. So that was the study. The study was to compare a group of patients with acute coronary syndromes that are treated medically to be randomized into the use of prasugrel versus clopidogrel. And actually the dose of prasugrel that was used was the same than in the acute coronary syndrome in the Triton study, 10 milligrams, except in the group of patients who were thin, less than 60 kilograms, and in a large group of patients who were over age of 75. So they took into account the side effect in the Triton study. The group of patients that were randomized was close to 7,000. And just to make a long story short, there was no significant difference at all between the use of prasugrel and the use of clopidogrel, which in a way is good news from economic point of view because clopidogrel is much cheaper than prasugrel. But at the same time, it tells us that if we use 5 milligrams of prasugrel, we may go back to the acute coronary syndrome that is intervened and use a lower dose on the patients that had bleeding, which were patients over age of 75, and the patients that were thin. I mean, this is a surprising trial, and I'd like to know how you take it. John, what do you think?
Well, I think this trial has a number of important lessons for us. I think the first is this was a trial designed based on the experience and results of an earlier trial, and I congratulate the investigators for building on this program. I think it's an endorsement that 5 milligram prasugrel is effective and safe. It is as effective and as safe as clopidogrel. I think the third element, the third lesson from this is we know that secondary prevention remains an important problem, an important challenge. And how do we move forward from here? Is the policy of adding antithrombotics, now that wasn't tested in this trial, but it just brings to my mind, are we doing the right thing as we move forward? It seems that additional antithrombotic therapy is going to be effective, but we pay for it with bleeding. Maybe we need to change the paradigm, and I'm reminded of the WOEST trial that we discussed earlier, 3 versus 2. Here it's 2 versus 2, but maybe we need to drop the aspirin. I'm just speculating as we move forward.
Or to use ticagrelor.
Or use ticagrelor.
In a trial basis. Not easy by the industry. You know, it's interesting when you look at the trials. The drugs are not one against the other many times because industry is not interested. This is a different subject, but I'm just bringing this up for discussion. Elaine, any comments about this particular study?
I think my only comment would be what we're seeing consistently, I think, across indication is that there's going to be a problematic group that's growing around the world, and that's age over 75, stage 3 kidney disease, prior stroke. We may not have such a problem with the weight, the low weight around the world, but you know, I do think that group is going to continue to plague us on what the right net clinical benefit is going to be.
Okay, Eddie?
Yeah, and I would just say we often try to categorize studies as a negative trial. I would say this is actually a very positive trial from the perspective of increasing our knowledge. The comparison of the two drugs showed equivalent results. That's helpful. The degree to which we're answering important questions in the elderly, as Elaine has indicated, is also going to be helpful. And then also buried in the study, but not yet reported, will be really interesting results on platelet function studies and its comparative on various doses as well as various groups of patients over time and ultimately comparing to outcomes. And I think the knowledge that will come from the study will make it a remarkably important one when we look back.
I like your point about we increase our knowledge, rather than saying a negative trial. Right? That's good. It's a good point.
It is.
Adrian?
Yeah, I think this is a great result for clopidogrel, which we use every day. It's inexpensive, and now we know it's as good as one of the better antiplatelet drugs. Plus, there was another message which we haven't mentioned, which is that patients on protein pump inhibitors, PPIs, on clopidogrel did slightly less well. And that brings back an old question, remember, that we were discussing 2 or 3 years ago about the role of PPIs in clopidogrel. And I think this reinforces that when we're using clopidogrel, those individuals should not be receiving PPI, because this is more evidence. It wasn't designed to address that, but I think it's something we should adopt in our daily practice.
Good.
Well, that's one view. I think the PPI clopidogrel story is still a very murky one. The best available epidemiologic evidence, I'm not sure, supports a negative interaction. PPI selects out people who do badly, and the randomized data from Cogent suggests no evidence of an interaction.
I tend to agree. I had to make a presentation recently about this issue. I became very confused. There are so many studies, one way or the other, that actually I don't have the... It's nice you made this comment, but your comment is also a pertinent one. There is a confusion in this field.
And I think even when you look at the pharmacogenomics and incorporate that into studies, it hasn't been demonstrated to have an impact. So it's interesting.
But it's a recurring finding.
Right.
Trial after trial.
We have to drill this one down.
Okay.
Caution for sure.
Let's move on. We have few minutes, and I still want to discuss a couple of trials that increase our knowledge, but were negative. And this is actually one on stent thrombosis. Stent thrombosis has been, like it was an epidemic, it has been decreasing progressively with time and trials and follow-ups, but it still is an issue of concern, particularly when it happens late. The study basically compared two different types of stent, the Cypher stent and the Endeavor stent. And the concept was Endeavor stent with a different mechanism of tissue healing would be protective from the point of view of thrombosis. And this was a superiority trial. Well, basically, the study involved about 8,000 patients from 36 countries. The name of the study is PROTECT. And the study actually was interesting because these patients were followed for a long period of time, 1 to 3 years. And basically, the question was the issue of stent thrombosis. And to go right to the data, was only 1.4% in the Endeavor group and 1.8% in the Cypher group. So there was no statistically significant. I think, frankly, one of the problems about this issue, I think the incidence of stent thrombosis is pretty low with the present type of pharmacological approaches. So, in a way, I'm not so surprised about this data, but I just like you to at least to make few comments. Maybe, Elaine, have you any comment about it?
I think on this one I will defer.
You defer?
I'll defer to my interventional cardiologist.
Okay.
I think this tells us how good not just the antiplatelet therapy, but also the technology, the use of IVUS and so on in terms of stent placement is so advanced now compared to 10 or 15 years ago that really,
that's probably
it's very hard to show small differences because we're so good at putting stents in there.
Eric?
Yeah, no, I would agree. I think it's a strong message that we are improving this outcome remarkably.
Shows another problem. Cypher stent is no longer on the market, so
what is the message then?
But at least it does well here.
So a tough trial. Another, I think the investigators did a great job in seeing this through. As you've mentioned, I think both of these stents are not that widely used, and the newer generation stents are going to have an even lower risk of stent thrombosis. But the most important message in my mind is we've been beguiled by concerns about stent thrombosis. How important is this? I mean, when it happens, it's not a good thing, but...
It's dramatic, but it's not important. It's dramatic when you have a patient that is stable, all of a sudden, a year later, 2 years later, develops a myocardial infarction and the stent is thrombosed. We all have seen these, but when you look at the overall incidence or prevalence of this, is pretty low. So I think this is basically the problem. It's very dramatic. It reminds me, actually, when I was president of the AHA, we did a survey of women who we asked the question, what is the #1 cause of mortality? And they said breast cancer, 75% of women. And I think it's the dramatic aspect of breast cancer that brings into the picture something like this. I think it's a similar situation. I think this is a dramatic event, but certainly the prevalence is relatively small. I'm not saying that cancer of the breast is not prevalent, but the comparison, I think, is pertinent. Any further comments for the surgeons? Well, this is not in your field, but...
No, I don't think I can add anything meaningful here.
Okay, so let's then move into, we have 2-3 minutes left, into something that you can call surprising, is the spironolactone. We all use these drugs in patients with systolic dysfunction, and they do more than decreasing blood pressure. As you know, they have a protective effect into the remodeling and connective tissue synthesis, extracellular matrix of the myocardium. So I think it was justified to get into patients with normal ventricular function and cardiac failure. These are the patients who have hypertension and otherwise who are very prevalent. And so the study evolved is the so-called ALDO-DHF study, was presented by Dr. Burkhard Matthias-Pisk from the Medical University Graz in Austria. And it's an interesting study on patients that actually were not very sick, New York Heart Association Class 2, over 400 patients randomized into spironolactone and placebo, normal ejection fraction, and cardiac failure. And the results were actually negative in terms of the symptomatology of the patient, in terms of the exercise capacity. May have been some decrease in the natriuretic peptides and in remodeling, but the fact of the matter, symptomatically, there was no difference. And the discussion of this paper was maybe these patients are not sick enough, and maybe you didn't have the sensitivity to see how this drug would work. But certainly is a blow to everybody who thought that this is the next step in normal ejection fraction patients with cardiac failure. Maybe, Adrian, since there are so many of these patients who have hypertension, what do you take from this study?
I mean, this was interesting because the RALS trial a few years ago showed the fantastic benefit of spironolactone in symptomatic systolic heart failure. And so this is an extension, but it's such a heterogeneous group of patients. Maybe some have heart failure, some most have hypertension. I think we need to see the left atrial diameter and dimensions in great detail to really examine who truly had diastolic heart failure. It's very hard disease to even describe, let alone characterize in a trial. And I think, as you said, the patients weren't that symptomatic and showed really no benefit, even though there were demonstrable changes in BNP and some echo measurements. So it's a study where the results give us some science, but no improvements in symptoms, probably because it's such a difficult group to study and they may not all have had heart failure.
Maybe sicker patients should enter in a study.
I think patients, we know already that patients with severe heart failure will do very well, but you tend not to see very severe heart failure who then suddenly have good LV function when you echo them. And it's such a difficult group of patients to call one condition. I think much of this is hypertension, and lowering blood pressure with spironolactone will be very effective.
It's frustrating, though. We see, you were talking about patients over age of 75, Elaine, and I think you are absolutely correct. This is what we are seeing today. There are so many patients who have diastolic dysfunction at that age because of a history of hypertension. They are short of breath. You measure the pulmonary artery pressures are in the 40s, in the 50s, and the question is what to do. And in a site of diuretics, we have very little we can offer for the myocardium thus far. So continues to be a frustrating situation anyway.
Yeah, I think we lower blood pressure as much as we can and we use diuretics and hope for the best. And that's about where we are.
Yeah. Eric, any comments?
No, I think you hit on it. The idea probably is to prevent this disorder as opposed to trying to treat now a condition that has been built up over a lifetime of a patient. The only other message I get from this was importantly already pointed out by Adrian is the idea of not satisfied with just biomarkers in this case. It's going to make also the symptoms be needed. Other studies also at this same Congress report some remarkable results in terms of biomarkers, but the degree to which that will carry forward is going to require, again, larger studies.
The other issue that perhaps in diastolic dysfunction or in normal ejection fraction with cardiac failure we should take into account, and this is evolving in the literature now, I was not aware, is these patients have so many comorbidities, and when you talk about mortality, this is not like the systolic cardiomyopathic patient with systolic dysfunction. There are many other things going on, and I'm not entirely sure. The quality of life is affected because they have pulmonary hypertension, but I'm not entirely sure how much the heart is playing a role in all this 50% mortality that we see around. It's just...
well, I think you're right. I mean, I think, and using spironolactone and these drugs which markedly affect potassium, see hyperkalemia. Remember the Canadian data shortly after the RALS trial, because using it in patients with widespread comorbidities and renal dysfunction, very dangerous drug, difficult to use. And so I think we should take from this caution about loading in spironolactone to older patients who've got some diastolic dysfunction. I think that's not the way ahead until we see symptomatic benefit and safety in those with good renal function, and those with impaired renal function. I think we can't use it.
And there was hyperkalemia as one of the...
Yes, there was.
Just for completeness, there was a study presented by Scott Solomon called the Paramount study. It was just published in the Lancet yesterday in the online. The angiotensin receptor neprilysin inhibitor, LCZ696, basically is a combination on valsartan in a drug that affects the peptide component of the myocardium. And the results were interesting in terms of affecting the parameters of the diastolic dysfunction. These were in patients with normal ejection fraction and BNP, and also some decrease in the symptomatology of the patients. I think this is a study still I would call is an opening door to perhaps other drugs that might affect other aspects of the myocardium. Well, I think we tried to cover as much as we could. I would say this was an interesting meeting, and I like what Eric commented on. Maybe it's a meeting that improved our knowledge somehow. I don't think there were studies that are going to change practice. Maybe the one on atrial fibrillation and the use of Coumadin clopidogrel rather than adding aspirin, is an interesting study. But it was an interesting meeting, and I would just finish by saying we have to open our minds about the issue of promoting health and prevention. We have a huge problem, and we have to be responsible for that and to do the best we can. I think this is important in this meeting. I think the issue of the technology like mitral clipping, I think is interesting if we can improve the quality of life of the patient, but we have to be very careful with the economics, with all these technologies that are so interesting and attractive. And finally, these trials that were surprisingly negative, but as we said, improve our knowledge, I think they were quite interesting. So I really appreciate all of you here. Again, I feel very, very good. This is a real international group from all different places, and I think was a good dialogue, and I really appreciate very much. And thank you, all of you, for your attention.